Hello everyone, we are studying the lasers in ophthalmology. So in our clinical setup, we have various kind of laser that we use on daily basis for variety of our procedures. History, coming to the history, in 1970 the first laser was built by Theodore Maiman using a ruby crystal medium. In 1971 neodymium yttrium aluminium garnet and krypton laser developed. In 1983 Trockel developed the excimer laser. This person is Theodore Maiman, who developed the first laser, and Golem A. Payman invented the LASIK. Trockel developed the excimer laser, and Rangaswamy Srinivasan developed the ablative photo decomposition and LASIK. Coming to laser versus light, laser is stimulated emission, monochromatic in nature, highly energized parallelism, coherent, and can be sharply focused, whereas light has a spontaneous emission, polychromatic in nature, poorly energized, highly divergent, not coherent, and cannot be sharply focused. So laser light is monochromatic, coherent, collimated, whereas non-laser light, flashlight, is polychromatic, incoherent, and divergent. Coming to laser physics, three basic ways for photon and atoms to interact are absorption, spontaneous emission, and stimulated emission. Okay, the components of laser are, first we can see, then these are the this is a tube which is containing the atoms. These atoms are energized to a high level, from 1 to 3 level. This is the pumping energy that is required. So these are the energy states of the laser medium. When these electrons get stimulated to a higher level, excited energy level, they spontaneously emit. Spontaneously energy emission is there to come to a lower level. Then they come at a metastable energy level. Then there is stimulated emission, which is called as laser. First is spontaneous energy emission, then first is absorption, coming then spontaneous emission, then stimulated emission. And this stimulated emission from a metastable energy level to a ground energy level is called as laser. So various lasers in ophthalmology are infrared laser, that is 1064 NdYg, that we use for yak caps, 810 nanometer diode laser in near infrared, 694 ruby red, 647 nanometer krypton red, 632 helium neon red orange, 572 630 dye yellow to red, 532 2x NdYg, that is used for photocoagulation, PRP laser, barrage laser, 514 argon green, that is also used for photocoagulation. Then 488 nanometer argon blue. Okay, 193 excimer, that is used for LASIK laser. Okay, so the visible spectrum, as we can see from the Vibgyor, violet, indigo, blue, G green, Y yellow, O orange, and red. So this is the visible light spectrum, and beyond that, till the 400 to 500, 600, and 700 nanometer is the visible light spectrum. Okay, then infrared, radio waves, X-rays, gamma rays, UV rays. Okay, so gamma rays, then X-rays, then UV rays, then visible light, then infrared, and radar, TV, FM, AM. Radio waves are even comes later after infrared rays. So delivery system are slit lamp delivery, laser indirect ophthalmoscope, fire optic cable, DLCP probe, endo laser. So classification of laser based on the basis of state of medium use. These are solid state, gas, metal vapor, dye, excimer, diode. Solid state are ruby laser and NdYg laser. Gas, argon, krypton and CO2. Metal vapor, copper or gold. Dye, rhodamine. Excimer में argon fluoride. Diode, gallium, aluminium, arsenide. Basis, what is the basis? Laser tissue interaction is there. Based on the laser tissue interaction, these are photothermal, photochemical, or photoionizing. In photothermal, there will be coagulation or vaporization. Either heat will coagulate the tissue or vaporize the tissue. photochemical, either there will be radiation or ablation due to chemical. ठीक है. Then photoionizing. Ionizing will surely disrupt the tissue. So coming to the various examples, photothermal photocoagulation is NDYG 532 diode laser. Then argon laser 514 nanometer. So this is the first one is our NDYAG, second one is our diode laser in the photograph. Photo vaporization is CO2 laser having 9000 to 11000 nanometer of wavelength. Then photo radiation dye 450 to 900 nanometer. Then photo ablation. It is a photochemical reaction in which we use the excimer laser for LASIK. Argon fluoride 193 nanometer is used, or krypton fluoride 222 nanometer is used. Photo disruption is NDYG 1064 nanometer and femtosecond is 1053. These two are photo disruptive. So we have photocoagulative, ablative and disruptive, all types of machines except photo vaporization and radiation. So we have to know that usually visible spectrum cause photocoagulation and ultraviolet yields the photoablation, okay, and infrared they are causing the disruption or coagulation. Coming to the photothermal effect, thermal either coagulates or vaporizes. So first coming to the first, coagulation. Laser light when fall on the target tissue generate the heat and denatures the protein. So rise in the temperature of about 10 to 20 degrees Celsius will cause a coagulation of the tissue. Double frequency NDYG is used. Argon laser, krypton laser, diode laser uses a trabeculoplasty, iridoplasty, retinal photocoagulation or cyclophotocoagulation. So these are the lasers for that is we have done the retinal photocoagulation with ND-YAG laser, that is 532 double frequency. Photo vaporization. Vaporization of the tissue to CO2 and water occur when its temperature rises 60 to 100 degrees Celsius or greater. Commonly used is CO2 10,600 nanometer. It is absorbed by the water of the cells and there will be a visible vapor that is that produces heat. When it produces heat called it does the cauterization, and when there is cell disintegration it causes the incision. So photovaporization we also have. Uses are lid tumors, blepharoplasty. Coming to photochemical effect. Photochemical means photo radiation or whether photo ablation. We have give the radiation or we have ablated the tissue. So photo radiation is used in the PDT therapy. IV photosensitive agent is given, that is verteporfin, taken up by the tissue. Sensitized tissue exposed to the red laser 690 nanometer. Formation of cytotoxic free radicals will be there, and examples are ocular tumors, CNVM, chronic CSCR. So there is abnormal blood vessels. There is circulation of the photosensitive dye to these areas. Cold laser, PDT is also called as cold laser. This activates the dye only in the abnormal blood vessels, and selective destruction of abnormal blood vessels will be there. Coming to the photoablation, when there is UV rays less than 350 nanometer, these break the chemical bonds. That is why we use excimer laser, that is 193 nanometer. So less than 350 will break the chemical bonds and that hold the tissue together into the smaller volatile fragments, and we have seen its application in LASIK, PTK, and we have excimer laser. Photoionizing will surely causes the photo disruption. So these are the highly energized focal laser beam 1064. It is delivered to the tissue over a period of nanoseconds or picoseconds, ठीक है, and produce plasma in target tissue. NDYG causes ionization, that is plasma formation, and increase in the temperature and expansion of that plasma, and there is shock wave production and causes the tissue disruption. So what is the difference between when we do iridotomy with argon versus Nd:YAG? Argon laser causes the photocoagulation, whereas Nd:YAG causes the photo disruption. Both have different lasers. 514 is argon and Nd:YAG is 1064. Inflammation is very common in argon laser, whereas Nd:YAG photo disruption, it causes less inflammation. Damage to endothelium and epithelium is there in argon laser. Nd:YAG have damage to endothelium. Bleeding is less in argon laser, whereas bleeding is more common in Nd:YAG laser. Iridotomy closure is common with argon laser and it is less likely in Nd:YAG laser. Coming to Nd:YAG uses, it is used in YAG hyalidotomy. Then it is used in YAG sweep when we set it as anterior. It is used for persistent pupillary membrane. Then it is used for anterior vitriolysis, or it can be used for Nd:YAG laser iridotomy as we have discussed. So the laser used is Nd:YAG 1064. Target is iris crypt or site under the upper eyelid between 11 to 1 o'clock nasal site, and energy is 4 to 5 millijoule, but in our setup we use 3 millijoule and 1 or 2 shots only. So number of shots are single pulse shots or up to 3 shots we can give. Lens for laser delivery. Focal and grid laser we can use Mainster and area centralis. And capsulotomy and iridotomy we are using the Abraham lenses. And for goniotomy we are using the Goldman style 3 mirror, or we are using mainly the Sussman for gonioscopy. Then PRP laser we are using Goldman style 3 mirror, Mainster PRP 165. Mainly we are using PRP 165. We have other as well, that is Volk Quadra aspheric, Volk Super Quad 160. Focal and grid lasers, Goldman style 3 mirror, Volk area centralis, Mainster standard. Then this is the old type of Rodenstock pan fundoscopic lens. Coming to lasers in glaucoma, when we have an internal flow block, we do iridotomy or iridoplasty. When we have an outflow obstruction, we go for laser trabeculoplasty or excimer laser trabeculostomy. Coming to laser iridoplasty, the argon green laser is used, 514 nanometer. It is done using the contraction burn. Spot size is 200 to 500 micrometer. Energy used is 300 to 500 milliwatt. Then duration is 100 to 500 millisecond. 10 to 20 spots are evenly distributed over 360 degree, and we usually do it in plateau iris. When each one is placed, there is contraction of the iris stroma, which leads to separation of the contact between iris and trabecular meshwork. Laser trabeculoplasty, okay, it can be laser argon laser as we have discussed, or selective laser. Okay. In argon laser we have a very small spot size, 50 micrometer only, and we give at a junction of the pigmented and non-pigmented epithelium, whereas our target for selective laser is melanin cells. Okay. And spot size is greater, 400 micrometer. Energy used is 700 milliwatt in argon laser trabeculoplasty, and number of spots are 50 initially in 180 degrees. Number of spot energy used is 0.8 millijoule. Okay. And number of spots are 50 to 100 only, and duration is 3 nanosecond. Excimer laser trabeculostomy, it is done intracamerally, 308 nanometer xenon chloride excimer laser. It delivers the photoablative energy. Firstly we make a parasynthesis, we take our fiber optic, it is advanced through the AC, placed in contact with the trabecular meshwork, and ablation hole is created through the trabecular meshwork and inner wall of Schlemm canal. So it is a type of stomy, we are making an opening. Coming to the lasers in retina, that we will be discussing the types of laser in diabetic retinopathy, macular edema, retinal tear, CSCR and ROP. Firstly, we use the green laser NIDAC NDAC 532 laser. It is absorbed selectively at the melanin in the retinal pigment epithelium, hemoglobin pigments and trabecular meshwork. These are the green lasers that we are using in our OT. First one, second one in our diagnostic room, that is used for photocoagulation. This is LIO, and these are the settings that we use. These are the glasses that we use while doing lasers, while watching at the lasers. Red diode laser, it is 810 nanometer near infrared laser. It offers increased patient comfort due to absence of bright flashes of light. Deeper penetration into the choroids is there, so it is the laser of choice in ROP. It is low cost, portable, small and high powered versatile laser. It can be used along with LIO. Coming to the lasers in diabetic retinopathy, PRP is effective in the following list factors. When the NVD is more than 1/3 of the disc area, NVD with vitreous hemorrhage, NVE with more than half disc area with pre-retinal and vitreous hemorrhage. Laser setting for conventional PRP at wavelength 514 or 532 nanometer, means we can use argon laser or green laser. Double frequency NDAC, duration is 200 millisecond that we use in our setup. Sport size is 100 to 500 micrometer. Power 250 to 750 depending on the sports color. Okay, so patent scanning laser uses the wavelength 532, duration is 20 millisecond, spot size 200 micrometer, power 300 to 750. We can see that normal retina looks like this. Optic nerve, center of the retina is macula and peripheral retina. So we have to spare the macula, which lies between the superior and inferior arcade, and we have to not treat the macula. Laser spots are not given in the center. Pan-retinal photocoagulation is done. So the location of PRP laser is 500 nasal to the optic disc margin, 2 disc diameter temporal, or above below the macular center, extending peripherally or to beyond the equator. So these are the patterned lasers, as we can see. So coming to the indications and mechanism, it converts the hypoxic area into anoxic areas. Destruction of badly perfused capillaries, thus diverting the blood to the healthier retina, and destruction of the leaking blood vessel technique. PRP is divided into 3 sessions with 1 to 2 weeks interval between the session, and diabetic retinopathy study and ETDR's protocol recommend 1200 or more burns separated from each other by 1/2 burn in PRP. Types of laser in macular edema, these are focal or grid laser. Okay, so first one is the focal laser that is done in the periphery. Okay, so it is green yellow wavelength area, direct treatment of the focal leaky aneurysms in the area of retinal thickening, 500 to 3000 micrometer from fovea. Spot size is 50 to 100 micrometer, duration is 100 millisecond. Intensity of burn is grade 3 burn. In grid laser, wavelength is green yellow only. Area, it is done in a C-shaped fashion, as we can see in the picture. No burn within the 500 microns away from the disc margin. Spot size is 50 to 200 micrometer. Duration is 100 millisecond. 500 micron away from the fovea. Intensity is light gray, 2 burns. Grade 2 burns. Retinal break or tears. Wavelength argon or NDYG laser. Mainly we are using the NDYG double frequency laser. Duration is 100 or 200 millisecond. 2 to 3 rows of burns are made around the hole or tear, and retinal spot size is 200 to 500 micrometer. Moderate in retinal whitening should be there around the lattice or any tear. See, in CSCR laser photocoagulation, frequency double NDYG laser is used. Argon or diode can be used. Energy is 100 to 200 milliwatt. Spot size 200 micrometer. Duration 200 milliseconds. So basically we can learn 200. So reaction should be mild whitening only. 2 to 3 mild spots are required. So we have to give just mild spots to resolve the CSCR. Though observation is done for a longer period so that it resolves automatically. In ROP, argon diode frequency double anti-YAG can be used, but we mainly use diode laser. So 900 laser spots are given in first session, power 200 to 1000 milliwatt. Lasers indicated any zone 1 ROP, zone 2 stage with plus disease or stage 3, zone 2 with less than 5 to 8 clock hours of stage 3 with plus disease. Zone 1, as we all know, that it comprises of optic disc and macula. Zone 2 till the nasal ora serrata with plus disease, where there is tortuosity of vessels, or stage 3 means there is formation of ridge. Then we go for lasers. Or zone 2 with less than 5 to 8 clock hours of stage 3 with plus disease. So these are the stages as we have discussed, that stage 1, stage 2 there will be demarcation line, stage 3 ridge formation, stage 4 partial RD, and stage 5 complete RD. And zones, as we can see, zone 1, zone 2 till nasal ora serrata, and temporal crescent is zone 3. Complications of lasers are journal complication, pain, decreased night vision, decreased peripheral vision. Anterior segment complications are elevated IOP, corneal damage, iris burns, crystalline lens burns, IOLPC damage, lens opacities. Posterior segment complication, choroidal detachment, exudative RD, choroidal subretinal vitreous hemorrhage, preretinal membranes, paracentral visual field loss, scotomas, photocoagulation, scar enlargement, subretinal fibrosis, accidental foveal burns. Diagnostic uses, we know we are using it in optical biometry, A scan, OCT. In A scan we have wavelength 1310 nanometer. In OCT we have infrared wavelength 840 nanometer. In COVA we are not using laser, it is a photograph. Scanning laser, SLO is there, ophthalmoscopy, fundus camera, angiography. SLAP test, the letter E is denoted to different visual acuity. It is projected on patient retina, and examiner direct test letters to foveal and extrafoveal locations are given within the macula and determine the subject potential visual acuity, that we do the test potential acuity. Then DSLR based photographs are taken our COVA machine, and these are the laser based fundus photographs. So there is difference between the laser and DSLR. SLO utilizes the horizontal and vertical scanning mirrors to scan a specific region of the retina and create raster images viewable on a television monitor. So it gives us a broader view as well. Thank you.